Hello, and thank you for joining us for the first program of this year's Alumni Weekend at the Harvard T.H. Chan School of Public Health, Rising to the Challenge, Public Health in a Changing World. My name is Erica Reaves, and I will have the pleasure of moderating today's panel, Closing the Gaps in Public Health Infrastructure, with an incredible group of panelists. I'll go ahead and introduce each panelist while asking them some opening questions and invite them to share a little bit more about themselves and their work. First, I'd like to welcome Dr. Yonatan Grad, who is the Melvin J. and Geraldine L. Glimcher Associate Professor of Immunology and Infectious Diseases at the Harvard Chan School of Public Health. Yonatan, to start off, please tell us a little bit more about yourself and your work, and answer the question, please. In your opinion, what gaps, barriers, or inequities do you feel the COVID-19 pandemic laid bare?
Thank you very much for the introduction, Erica, and wonderful to be here with the other panelists and with you. So a little bit about myself. So I trained clinically in internal medicine and infectious diseases, and I have a research background in areas from microbiology and genomics to epidemiology and mathematical modeling. Prior to the COVID-19 pandemic, we worked on questions related to another pandemic, that of antibiotic resistance, as well as trying to understand the spread of viruses through populations, looking at questions like why there were mumps outbreaks in highly vaccinated populations. So you can understand when the COVID-19 emergency arose, we switched to focus heavily on it. And that included work starting early in 2020, in which we were modeling the course of the pandemic, making the forecast, which was fairly unpopular and unwelcome at the time, that this was going to be a years-long saga, not something that was going to go away by Easter. And we've continued working on COVID-19 in multiple ways since, including working with the National Basketball Association to help design the bubble for the resumption of the 2019-2020 season, and then continuing as an NDA science advisor since, and working with public health institutions to both understand and respond to the pandemic. The question you ask about gaps, barriers, and inequities is a big one and so important. We've seen really disturbing inequities in so many ways. The burden of disease and death from COVID-19, for example, we've seen that there are much higher rates in Hispanic, non-Hispanic, Black, and Native American populations when adjusting for age. And it's I think, both shameful and something we really need to address. We've seen access to care and vaccination rates that have varied widely across communities. And here, as a country, we're doing very poorly. Why is it that we are among the lowest, if not the lowest, or why are the rates the lowest, if not the lowest, for vaccination and boosting among high-income countries? How can we address this? There's also a recent New York Times article about the challenges that the CDC and other public health institutions face in collecting relevant data to help inform our understanding of epidemics and the impact of interventions. How do we address these challenges? And even where we have new tools that have been so useful in the context of the pandemic, like wastewater analyses, these raise questions about inequities that I think haven't been fully addressed. There's a question that I learned from Josh Solomon, who used to be here at the Harvard Chan School and is now at Stanford, where he asked, for any new technology, to what extent does it exacerbate or alleviate inequities? And I don't think that even for something like wastewater, we really have a good grip on this issue. What sections of the US use septic tanks? And so wouldn't actually share information that we would gather by looking at wastewater from sewer systems. What is the demographic makeup of those sections? So I think there's a lot that we still have yet to learn about to the extent of inequities, even with a lot of the innovations that are going on.
Great, thank you. And there'll definitely be, I'm sure, questions from the audience. And I have some follow-up questions so we can get into what, as you framed, was a very complex question to ask. So thank you so much for your comments. And next, I would like to introduce Marquisha Johns, who's Associate Director of Public Health Policy at the Center for American Progress. Thank you so much for joining us today, Marquisha. And also, please tell us a little bit about yourself and your work. And I'll ask you the same questions. What gaps, barriers, and inequities do you feel the COVID-19 pandemic laid bare? Thank you.
Thanks, Erica, and hello, everyone. As Erica mentioned, I work at the Center for American Progress, which is a think tank based out of DC, and we work on a whole host of issues. And obviously, what I work on is public health issues out of the center. And actually, that public health section of our health team is relatively new. Started just within the past year, but we've been focusing a lot on public health infrastructure, social determinants of health, and especially building those connections with our other teams who work on the different social determinants of health issues, whether that's poverty or climate or education, working across all those teams to really make sure that they understand the health implications of their work. And when they do advocacy, to also incorporate those health implications. And so that's a little bit about my work at the center. In terms of my background, I am trained as a lawyer, so that is what I did shortly before joining the center. But while I was in law school, I focused a lot on health law, health policy issues, and so worked on the Hill, on the Senate Health Committee, also worked at CMS doing some regulations, things like that. And then prior to actually starting law school, I worked a lot on a Section 1115 Medicaid demonstration waiver out of the state of Missouri. And so I have a background, and then obviously I have a public health degree as well. And so my background kind of lives in between public health and traditional healthcare. And then as far as your questions, I'm going to hit on some of the same themes that were already said. And what I really want to talk about is the data gaps that were really just highlighted during COVID. Our data systems are completely outdated. I'm sure many of you know how bad it was even at the beginning of the pandemic, where health departments were still using fax machines and manually entering data and things like that. And so those efforts are really time consuming. And then we have systems that don't talk to each other, like systems that collect data through contact tracing, don't talk to those that track test results. And so we have scattered data that we're not really blending together well to really get a full picture of what's going on, not even just with COVID, but generally with just public health issues. And so, and then obviously we have the issue of workers who we just don't have enough workers who are processing the data, analyzing the data, things like that. One of the things that we saw a lot too was just the lack of demographic data, which is extremely problematic. We don't have things. We don't have a lot of comprehensive data around race and sexual orientation, things like that. Really key data that helps us to further health equity by being able to target resources to the communities that need them the most. Outside of that, we don't have, federal agencies don't really have the authority to demand data from state and localities, nor can they really standardize this data. So that kind of contributes to how much the data is really fragmented. And this is the data that's flowing up to CDC. And this is the data that we're using to create our national picture of what health looks like. And so that's really concerning. And during COVID, we really didn't have the data that we needed. We had to rely a lot on international data to really understand what was happening with the virus and what steps to take. And we're relying on international data, fragmented data, all of that to really guide our policy decision and our guidelines, which is not good. And we end up paying for this when it comes to people's lives and their health, when we can't really respond quickly because we don't have the data. And this is the same thing that we saw this happen during COVID. We saw it happen again during monkeypox. Where we really didn't realize how much inequities existed in the monkeypox response until months later, after the outbreak had really peaked, is when we learned how bad the racial inequities were and how many Black and Brown people weren't really getting access to vaccines. And so even though there's been a lot of money that's flown into data modernization over the last couple years, we still really don't have great systems, especially as we're going into winter and a possible surge and the new bivalent booster, to really be able to really accurately say, where are we with COVID and how will this booster take us into the next stage of the pandemic? And so one of the things that we advocate for is sustained investments for the public health and for public health infrastructure and for the system. And without those, we've had a lot of influxes over the last 2 years temporarily, but without continued sustained investments, a lot of the improvements that we saw in some of the data systems, or even improvements overall throughout the system, it's going to be really hard to really stand those improvements up to have them be long lasting beyond the pandemic if we don't continue to invest the way that we need to. There's been so much investment in modernizing healthcare data systems and EHRs and things like that. And so we need to see those same concerted efforts when it comes to state, local, federal public health data systems.
Great, thank you so much. And last but not least, I'd like to welcome Nason Maani, Dr. Nason Maani, who's assistant professor of Inequalities and Global Health Policy at the University of Edinburgh's Global Health Policy Unit. Nason holds visiting positions at the London School of Hygiene and Tropical Medicine, as well as Boston University School of Public Health. He's a fellow of the Royal Society of the Arts and was based in the United States from 2019 to 2021 as a Harkness Fellow. Nason, I will ask you to do the same. Please tell us more about yourself and your work, and any thoughts you may have on gaps and barriers and inequities laid bare by the pandemic would be very useful to hear. Thank you so much.
Thank you so much, Erica, and thank you very much, the organizers, for inviting me to this event. I just want to address the elephant in the room, which is that I'm not an American, and I'm not currently based in the US. And my work in the US is very much colored by that. So I hope to offer an outsider perspective a little bit to some of these issues. I was born in Northern Ireland originally in the 80s, so a very segmented country at a time of great political and social instability. So, in some ways, the US in 2019, 2020 was pretty familiar to me. And my research has largely centered on the structural and commercial determinants of health and how they shape health inequalities. And beyond that, how they shape how we talk about policy and policy options, and how knowledge is formed, and which types of evidence do or don't feature in policy-making decisions. So when I think about the gaps, barriers, or inequities that the COVID-19 pandemic laid bare, I agree very much with what my co-panelists said. I suppose to complement that perspective, I would say three things. I think first, it exposed gaps that were actually long-standing along many dimensions. So the US population health was already lagging behind most of its peers pre-COVID. Life expectancy had actually already started to drop pre-COVID, which was unique among its peers. It had about twice the NCD burden of the OECD average, so there were ways in which the US population was really failing, its health was failing a little bit pre-COVID-19. And I think that's really worth bearing in mind because even, in the first wave of COVID, mortality rates among white working age Americans never got as high as the mortality rates among black working aged Americans pre-pandemic. So even in the height of the first wave, when we were locking down and trying our very best to control the virus, we were doing that to avoid a risk that was less than the risk of death that African Americans walked around with pre-pandemic, if that makes sense. So there were these really long-standing gaps. The second thing I would say is that it exposed the gap between those most affected by the wider determinants of health and those who were in positions of power, decision makers, the media. I think our discourse around COVID-19 was often quite polarized and wasn't very nuanced, especially when it came to how to help the most marginalized, and we saw a little bit of this. I mean, the US had a huge prison population at the time. It was about 2.1 million, now about 2.3 million. How do they socially isolate? There's about over 100,000, maybe closer to 200,000 homeless children in America who do go to school. How do they deal with school closures? Around 65% of African American kids are in single parent households, and 1 in 3 African Americans could work remotely. Like, what do those things do for those communities, and how do we enact COVID policies that don't widen longer standing disparities, right? Like, how do we offer them support to offset those things? And I think so that gap to me emerged, like the gap between, the necessity, the medical and health necessity, and the understanding about who's affected the most and what their position is like. And the third gap, I think, is between healthcare and everything else. I think pre-pandemic, our discourse around health was really around healthcare, or the presence or not of universal health coverage. And I'm here to tell you that, I live in a country with universal health coverage, and there are huge gaps in life expectancy. It's not a panacea. And a lot of what the inequities that were exposed were unrelated to healthcare. Some of them were, but many of them were related to disparities in income, and ability to work remotely, in working conditions, in education, all these kind of things. So I guess it exposed the gap between what a healthy healthcare system would look like in America and what a healthy America would look like. And those are two different things.
Great, thank you all for those opening comments. And I think given, the diversity, among the three of you, in terms of lived experiences, your academic backgrounds, and what you're working on, and how you just answer that question in terms of prioritizing their answers. I'm wondering if I could ask another kind of foundational question just before we move forward into more direct questions. What is public health? How would you answer that question? And how does it differ from how we tend to define it in practice? And anyone's welcome to start.
I mean, I can have a stab at it. I don't want to monopolize, but I can start. Others can say. I think the definition of public health I prefer is the one by Acheson. So Acheson wrote a pivotal report in the UK on inequalities, and his definition of public health was the science of preventing disease and promoting health through the organized effects of society. So it wasn't just about public health practitioners, if that makes sense. It was more about the art and science of improving health through how you organize your society. And I think maybe that differs a little into how we have come to view public health, especially in the US, which has often, I guess, lent more medical maybe, and lent a bit more downstream. And some of that's through necessity, but there are downsides to that.
I can jump in here. This is a very tricky question. I think it's really hard for us to vocalize what that is as practitioners, and that's something that the public health team at the center has been really grappling with, is how to define public health and how to communicate what it is. And so I don't think that I have all the answers, but I will just repeat something that I heard at another conference that it stuck with me, and I thought it was really powerful. Someone said that if you imagine a fish tank, public health is the water in the tank. That the water in the actual tank, and not the fish, the individual fish. It's the conditions of the water, it's the conditions of the tank. So how do we improve those conditions so that the fish in the tank are healthy? And so I thought that was pretty powerful, but I think this is a really important question, and it's something that we as a public health community really need to get our hands around. How do we explain what we do? How do we communicate what this is? Because it's really impossible to get the public to care about it and to get policymakers to care about it and spend money on it if we can't communicate what it is that we actually do. And it's difficult because the stuff that we do is in the background, and a lot of people don't realize that it's there and it's working until it went wrong, like with COVID.
I love both of those answers. Each of them, I think, gets at, I think, key issues. One being public health is a reflection of the values of the society, that we have to make a determination of what we prioritize. What do we care about? What do we want to invest in? And a second is the recognition that we are in the same bowl, right? So that much as you might like to believe that we are all in individual bowls, in fact, our environments are shared, right? And the decision making that we make for ourselves as individuals is also a reflection of how we think about our place in society and as a member of a community. Just as we might think of the hidden aspects of public health, our infrastructure, our sewer systems, our access to clean water, that is public health. The fact that we want people to wash their hands as restaurant workers, that is also public health, right? So these are elements that stretch from the everyday decisions we make for ourselves to large scale infrastructure for our society. So it permeates each element, I think, of lived life as an individual and as a member of society. And broadly speaking, as we're seeing again and again, is a reflection of where we as a society put our values and how we value human life.
Okay, thank you. And Marquisha, if I may turn to you with a more direct question, I think picking up on some of your opening comments, particularly about sustainability. So what happens, so-called post-pandemic? And we know that there's a continuum, I'll say, of understanding and feeling about where we are in the response, and has the pandemic ended? Are we moving more into an endemic phase of this public health response? But we know that the emergency continues to, test the public health safety net, from access in the US context to Medicaid for low-income individuals and families, to ensuring access to broadband internet in the home, let's say, so that, again, individuals can participate in, let's say, digital visits with clinicians. So in anticipation of the end of the public health emergency, whatever that may mean to you, and whenever that may happen, what are the public health policies that you feel are vital to the future of the safety net in the so-called post-pandemic phase?
Well, the way I'm interpreting that question is really, I guess, very specific to the actual declaration of the public health emergency, and thinking about all that has allowed us to do, and the potential end of that come January 2023. And so I think the thing that we're all really concerned about, and I know obviously public health is more than healthcare, but you already called it out, is Medicaid access. With the end of the public health emergency comes the end of the continuous enrollment requirement that has allowed so many folks to remain in coverage over the past couple of years. And just the amount of people who will lose coverage once that's turned on is really startling. I'm seeing estimates of 15 million people will probably lose coverage once that's turned on, depending on, different rates by the different states and what protection states put in. But there's a risk of 15 million people losing coverage, with about 6 million of that being children. And so this is really alarming. This is a massive influx of uninsured people. And I think this is specifically relevant for public health because we're also at the same time seeing the increasing privatization of COVID. So testing, vaccines, treatments, all of that is moving into more of the private insurance, the health insurance space, right? And so we know the COVID-19 uninsured program has ended already. There's no funding for that. And so as millions of people are going to be dropped from coverage, they're going to struggle to access testing, vaccine boosters, treatments, all of those things. And they're going to struggle to access that and also pay for it. And so I think this is something that is a really big issue that we need to be focusing on. While obviously public health is more than just the medical coverage, a lot of people will struggle to access COVID testing, vaccines, treatments, which will just continue to hinder our response to really get our arms around COVID. I personally don't think we're out of the woods yet. I'm sure many people on the call also may agree with me. And so if that happens, where does that leave us with our response to COVID? And where does that lead us with our movement into the endemic stage? So I think a lot of states, and I'll say this, a lot of states are already thinking about this. They're already considering how to reduce the coverage losses and how thinking about marketplace transition and things like that. And so I anticipate that a lot of states will put in some type of protections around this for their Medicaid rolls, but this is something that we do need to be thinking about, because if we have more uninsured people who don't have access to COVID vaccines, testings, treatments, all of those things, then where does that leave us?
Thank you. And to pick up on your comments around testing and treatment, in highlighting the role of private corporations, in the public health response, and maybe Nason, if I could transition to you. I know that one of your research interests is corporate determinants of health, and I was wondering if you could provide some insights or predictions about how corporate practices on health will shape the future of public health infrastructure.
Yeah, sure. I mean, you kind of put me on the spot there on a slightly a very related topic, I think. But yeah, so my research on the corporate or commercial determinants of health, it really centers on the way in which the activities of the private sector, segments of the private sector, can be incentivized in ways that are oppositional to public health. And that can happen in lots of different ways. An obvious example might be the activities of the tobacco industry, right? To increase doubt around the link between smoking and lung cancer, because it allowed them to continue making money for a lot longer. But another way is certainly around profiteering during the pandemic, right? And we have these instances where there are pretty strong conflicts of interest between the need for rapid, reliable, cheap testing, diagnostics, treatments, and I guess quite powerful lobby seeking to conserve as much patent protections as possible. And that kind of played out on the global stage with initiatives that tried to improve vaccine access and coverage, but ultimately weren't quite successful. So, the African continent is still very under vaccinated compared to every other world region, basically. And I think what's helpful for us in public health is understanding that corporate actors they shape our environment in powerful ways. And if, like you say, if we care about the goldfish, the water in the goldfish bowl, then we should care about how corporate actors shape that water or pollute that water. And that doesn't just mean physical pollution of our environments, but it means pollution of our discourse, like throwing in evidence or priorities that are not evidence-based, that are biased. And so I think there we do have a lot to learn, a lot to pick up on. We have a study coming out soon that looks at how the U.S. Healthcare industry has lobbied against expansion of Medicare, Medicaid, and the kind of arguments it's used. And it's really striking how similar those are to other industries. Even though it's an industry that deals in health, they talk about, government overreach, and they talk about a slippery slope to like a dystopian future, and they make really powerful arguments against universal health coverage, motivated by, obviously, for profit. So I think it's important to bear witness to these forces if we want to improve the quality of the water in the goldfish bowl.
If I may, I'll add just picking up on some of those points that I think are excellent and well made. We can look at the cost of insulin, right? Life-saving medication that is where the price in the U.S. is wildly inflated compared to other places in the world. And similarly, building from that example to broad experience of healthcare costs in this country. We pay the most, and yet our health outcomes are among the worst in comparative groups. And so there are huge challenges there. And then, I think this was a point that Marquisha made as well. We don't have the National Health Service or the other kinds of tools that other countries were using to help inform response to the COVID-19 pandemic. Really being able to query what is going on in a population, looking at the impact of variants, of different interventions, of vaccines, and through access to these healthcare outcomes, really getting a sense of how to inform response most appropriately. We don't have those kinds of structures here in the US. And instead, we have to turn to private industry. We have to turn to something like Kaiser Permanente and ask them for help in answering these key questions. We don't have the ability to do that through our public health institutions in anywhere near the same.
Great, thank you for those additional comments. And if I may just switch gears a little bit and return back to you, Yonatan. I had a question about in your study and communication about the evolution of pathogens. I wonder if you could speak to the most effective approaches for engaging or educating or empowering laypersons to understand their role or roles in, let's say, infection control or reducing disease burden, excuse me, excuse me, or being a public health practitioner in their own communities. Any thoughts you may have would be appreciated. Thank you.
Boy, such a hard question. It's fun too. But
Sorry.
no, it's such an important one, and I think it gets at some of the, I want to say it's something about where we are in this moment, right? This political moment where something like COVID-19 could become immediately politicized, something that you would think, because it is a threat to the whole population, would bring us together, and yet it has itself become polarizing. I think it's because we are in an environment where everything is becoming polarizing. It's like there are two magnets out there and kind of drawing everyone, no matter what the topic is, to diametrically opposed views. So how do we overcome that? How do we get people to think about themselves as members of communities? It's the topic I think most people point to is trust, right? Trust in leaders, trust in data. We talk about trust in science, right? But everyone right now feels like all of these things are in some ways themselves infected by politics, right? That there is somehow everyone has an agenda, and that there isn't the sense of our being part of a united front to protect each other, to value each other. So how do we overcome that? How do we establish that trust? I don't know. I wish there were good answers out there. I think leadership is got to be key, right? People who are able to effectively communicate the notion that we are here as a united group, right? We are all part of the same community fundamentally, to try to protect each other and take care of each other. But getting that message across and in a convincing way is, I think, has proved immensely challenging. So, on the one hand, I think people really agree that yes, they should wash their hands before serving food or, as part of restaurant workers. And yet, by the same token, people are unwilling to wear masks, right? With the same principle, right? Protect others around you while also protecting yourself. And yet some messages get through and others don't. It's, I think, a terrifically challenging environment right now.
Nason or Marquisha, any additional thoughts?
Yeah, I think Yonatan's point is a really powerful one, and it goes back to what Marquisha was saying a little bit too. One of the amazing things about the US, and it's a country and people I've come to really love, is its size and in some ways its interconnectedness. Like the states, the federal system, it offers the opportunity for a huge amount of diversity in a really large country, but that is in some ways one body. They're like the parts of one body. And I think, like what Yonatan was saying, there's been this long-standing culture of not viewing the entire body as needing to be healthy. You know what I mean? It's like having a patient, but a patient where you're the doctor and you only define the patient's health based on their left arm. Like, well, your left arm is looking perfectly healthy, so you're fine. You know what I mean? And in a way, I think public health infrastructure is like the nervous system that lets you know about all these other problems that are going on. It's the one that sends pain up the receptors to tell this segment of the population is suffering. This segment is experiencing worse outcomes. Does that make sense? And I think if we don't have that kind of strong, centralized system that can communicate to each other, then those disparities will linger and fester, and that has a whole host of negative consequences, not just for those parts of the body, but for the whole body. Does that make sense?
I completely support what my panelists have said. I just want to flag for Nason that I love taking these one-liners from conferences, and so I will be using public health as like the nervous system.
I agree. That's a great line. I love the analogy.
Great, thank you. And so before we move to the question and answer portion of today's webinar and engage our virtual audience, I have one additional question for the three panelists. And sorry, I feel like I've been setting you all up all afternoon or evening, depending on where you are. But if you have any thoughts, what is or will be perhaps the greatest achievement in building or strengthening public health infrastructure in the 21st century?
I think I'll jump in here. I think that, that the has or will be puts it in many different ways, and also thinking about the scope, right? Are we talking about global public health? Or are we talking about public health in the US? Because globally, I think there are still so many fundamental issues that we need to address. I made reference to sometime earlier having access to clean water and a sewer system, right? A huge fraction of this world does not have that basic infrastructure. And if we think about the impacts that has on health, I mean, they're vast. We are still in the 7th cholera pandemic globally. We don't have to deal with it here in the United States because we have access to clean water and sewer systems, right? It is not an issue for us, but in much of the world, it rages on. So thinking about what we should have as priorities, there are these basic fundamental elements of infrastructure that I think we need to distribute globally to help address these longstanding challenges and inequities. So as we target what could be triumphs of public health, I think that would be one. In addition to, as we've I think all of us have made mention of, just the inequitable distribution of our interventions, not just this kind of infrastructure, but vaccines, drugs, all around the world, right? Trying to make sure that the tools for individual health that impact population health are made widely available.
So when I think about this question, I think more about the different tools, and Yonatan mentioned it earlier, but I think wastewater monitoring is a really big and important tool that we've really built out. Thinking about this based on the US, we've really built that out during COVID. And I think it's going to be extremely valuable for tracking diseases and outbreaks in the future. And while it's not perfect, obviously there are equity concerns, as was already mentioned. I think this is a promising tool that if we could figure out how to make sure we implement this equitably, like we need to figure out how to implement everything equitably, it has a lot of promise for how we do public health and how we track threats, especially given all of the data concerns that I mentioned earlier, how difficult it takes to get data down from pull data from clinical settings into public health systems and then pull it from local to state all the way up to CDC. That takes time. And one thing that is good about the wastewater monitoring, as we're setting up more and more sites, that is really efficient. We can get results on that pretty quickly and get somewhat of a picture of what's going on in the community. I think last time I read, there were like nearly 1,200 sites set up in the country that were conducting this, and it's still being built out. CDC is continuing to invest in this, but I think it really gives us a good picture of what's happening in a community before we get that data, because of all of the data lags and all of the hoops that needs to happen in order for us to get those national pictures. But before we get that, we can start to see what's happening in communities as we're tracking this through wastewater monitoring. And so I think this is a really important tool for our preparedness efforts and for our ability to really respond to stuff more quickly, because we haven't been able to do that yet.
Yeah, I mean, I think these are fantastic answers. I mean, I guess to complement them, I might be maybe more broad and aspirational at the US level. I think when you look at the longer term history of public health and population health in the US, I think funding has been largely reactive and fragmented, right? And very, very siloed. So you didn't get, and that has a number of downsides. It's hard to build up a really competent public health workforce that have careers they can believe in and a job they are proud of, and are flexible. You know, they have these core skills that they can apply to whatever problem happens to emerge down the line. When instead you have reactive siloed funding, you have kind of a general lack of ability and then a sudden influx of cash for Zika or a sudden influx of cash for COVID. And it's very hard. It's kind of like the house is on fire and you're going to hire more and train more firemen. You know, it's kind of a little late to do that. And then they're going to be out of a job 2 years down the line, you know, when that's. So I think the biggest success for me would be public health moving from being reactive to being proactively built, and it being seen as a foundation upon which the nation's prosperity is built. It's not a party political thing. You know, it's part of life, liberty, and the pursuit of happiness. You know, health is the means to any end. So that's kind of foundational, right? It's foundational for security. It's foundational for prosperity. And yeah, I think that would be great. And knowing that the next generation of public health professionals have a sense of security about the competencies they're gonna acquire and the range of threats they're going to be able to respond to flexibly.
Thank you. And I would invite the audience, if you're able to provide your questions or comments in the chat, or there's also a Q&A feature. And thank you to those who've already provided some insights on your lived experiences and thoughts on the comments from our panelists today. So please continue to do so in the next 15 minutes or so. But if I can paraphrase one comment and question that came in, saying that, you know, we don't have a healthcare system, we have a sick care system that is largely reactive instead of proactive. And knowing that prevention is really at the heart of public health. Any thoughts on tools or strategies or approaches for really changing kind of the model of care so that public health just has a greater role, whether it's in the public's understanding of the system and its components and their ability to engage and be proactive within that system. Any thoughts you may have on that comment and follow-up question would be appreciated. Thank you.
It feels like this is a reminder of just how much public health is in the background of so much of life, right? That it's we pay attention only when there are huge issues, right? Like when all the planes are landing safely, right? It's no one notices, right? It's only when there's some catastrophe that it really garners attention. We've seen it play out again and again in public health, not just in this country, but in many places. You have successful campaigns against dengue, for example, and South America or Central and South America, and you see then that people pull back on those efforts because dengue cases have dropped down, but pulling back on those efforts just means that the cases will return as they did, right? So, it's the continued investment and recognition that success is the absence of these catastrophes is critical. So maintaining that investment in public health seems like that foundational start to that again is critical for shifting to a more prospective stance.
I think this question requires a huge philosophical shift in the country, which I do not have the answers on how we achieve that. But this really takes everyone viewing health differently. And I think everyone knows the right word to say, like social determinants of health, all of that, but we don't necessarily put the money behind those words. We don't actually connect those ideas to the work that we're doing. And so I think this really requires us to think about health differently, especially providers who are working in healthcare systems, right? You're not just providing medical care, you're trying to make a person healthy. And so how do you contribute to social determinants of health? How do you contribute to public health? How can you think about your work more holistically so that you're furthering public health? Another thing that we talk about a lot in the center is that there is no one who is lobbying on behalf of public health. Healthcare institutions, they have a whole industry of people lobbying for investment and really able to communicate the need for funding. And this is why we spend so much on healthcare, but only 3% of that really goes to public health. And so how do we rebalance those efforts? How do we get healthcare institutions to really realize how integral public health is to their work, so that they can not only can they start investing in public health more, but how can they use their advocacy tools to also get more funding and investment for public health? And so I think it requires coordination between health departments, healthcare providers, social services, all of this. So this question just really requires everyone to just recenter what they think of as health. And it's tough because I think a lot of people think that they think about health holistically, but maybe don't actually operate as if they think about health holistically beyond medical care.
Yeah, I totally agree. I think I've been really influenced by the work of Sandro Galea in this space. I think he actually might be the person who used the goldfish metaphor that you mentioned. He has a book called Well, What We Need to Think About When We Think About Health. And it's actually just about everything except for healthcare. But he uses very plain speaking language to kind of explain the relationship between power and health, and money and health, politics and health, environment and health. And I very much use that as a manual for communicating on the public health. And he talks about the need to make this shift. And part of that shift is actually that hospitals and treatment centers they can never be the protagonists when it comes to the social determinants of health. It's a little bit like, going back to that, the firefighter analogy. It's like firefighters being the protagonists of climate change. Like the true causes of why they're dealing with these fires sit way upstream of them. You know what I mean? And so part of that shift has to be the shift of responsibility for health, from it being just about healthcare and clinics, doctors, and medicine, to it actually being a societal responsibility. And I think tangible ways to do that. I saw some really innovative use of data dashboards, for example, in the UK during the COVID pandemic, where they had dashboards on the social determinants of health that they were updating just as they were updating COVID cases. And it was quite powerful because it was really showing and the UK Health Foundation has done some work on this as well. it was really showing in a kind of live observatory style way the amount of deaths we were suffering due to poverty or to low education or to air pollution. You know what I mean? And actually making those dashboards front and center and linking them to these non-health sectors. So I think there's work to be done on the data side there too, for sure.
Yeah, thank you all. And I just want to say that I misspoke. Please use the Q&A feature, not the chat feature. I didn't realize it was disabled for folks, so I'm sorry about that. And we have another question, which asks about the adequacy of public health education in grammar school. So it notes the USA specifically, but I know that, obviously there's global impact there. And that question assumes, access to formal education around the world. So if you could speak to those education disparities and inequities, but also for those who do receive formal training, is the public health education adequate for preparing individuals and families to be in the know about what's happening around the water, that's, the condition of the water around them, and if they so choose, how to be more active in terms of public health advocacy or being a public health accomplice in addressing some of those social drivers of inequities.
I mean, that's a really tough question. Again, these questions are really tough. I can start off on this one if it pleases my co-panelists, but we, as part of our work we were involved in a commission between Boston University and the Rockefeller Foundation. It was on data, determinants, and decision making. And as part of that commission, we conducted surveys across a range of countries around the world, some high income and some middle and low income countries. And we surveyed panelists on what they thought the most important factors influencing their health were, and compared this in different countries. And what was actually kind of striking was that the US, and there's a paper about this coming out soon, if it hasn't already, is that the US was among those that viewed genetics and healthcare as the most important drivers of health, more than countries in Africa, for example, or India, where they viewed the built environment and education as actually being really important for health, right? And I thought it was really striking because of everything we've talked about to date. It's been about the social determinants of health and health inequalities and the role they play. But actually in the mind of the public, at least according to that survey, that doesn't really penetrate through. So I think the answer to your question is, I don't think the story is really being told, to families in that way. And I think that's kind of disempowering, unfortunately, because I think unless you understand the true drivers of these things, it's harder for you to know what to advocate for, it's harder for you to see potential injustices for what they really are. And actually, when you think about genetics and healthcare, those are also kind of self-blaming. You know what I mean? You're saying, I'm sick because it's been down to me as the individual. It's my genetics, my behaviors, my lack of access to healthcare. And that's kind of the opposite of empowering, where you're saying, actually, no, it's these forces out there and you can go do something about those. You can advocate for better quality housing, for healthier classrooms with better ventilation, so on and so on. So I don't know if that answers your question, but hopefully it's a start.
I should say I'm no expert on education, so it's hard for me to speak to this with anything other than my own individual experience. But what I would say, if I were looking at this question, it seems like the key elements to be taught are critical thinking, foundational science knowledge, and civics, right? To really understand your place in your community, your place in the country, to be able to assess information rigorously, and then to be fluent enough with science that you feel comfortable doing that critical analysis. Those seem to me like the key elements. How well we do that, or how we can do that better, that gets, I think, far out of my comfort zone. It's not an area that I can speak to well, but those seem to me that, again, 3 pillars for focusing on these questions.
And I'll just agree with my co-panelists here. Also not my area of research or expertise. And so all I can really say is my personal experience as well. And I don't think it's being taught. I didn't even hear the term public health until college. And so I don't think that that conversation is being had in K through 12 school systems.
Wonderful. Well, thank you all. I think this conversation could continue for hours. I want to thank you for your reflections and really rich comments, your calls to action, and the ways that you have encouraged us all to think about our contributions to public health and better understanding the world around us. So thank you. It's been a pleasure meeting all of you and again, hearing your insights. I want to thank the Office of Alumni Affairs. Thank you for the invitation and for pulling this and other events together. Excuse me. If you're joining us today from outside of the Boston area and you're not able to attend the remaining in-person Alumni Weekend programming, which will occur tomorrow and Saturday, please note that some of the sessions will be live streamed and available on the Alumni Weekend website. And we will share, great. And I think the link will be in the chat shortly. So thank you to everyone. Be well. And thank you again and take care.